And thank you very much indeed to the organisers for asking me back here. We've got a long tradition in Oxford of having people over from Sri Lanka who've done some wonderful research, and not least amongst those is Charles Anthony Pillai, who wrote the definitive paper on Russell viper envenomation and its effect on hypopituitarism. And some people in the audience hadn't even heard of it as a cause of hypopituitarism until this morning. And so I think it's a really important piece of work that he did and set up a fine tradition of people coming from Sri Lanka to Oxford. And I'm very, very grateful to you for asking us back here. So thank you very much indeed. I'm going to talk a little bit about pituitary tumours and concentrate on things that I think are things that we've done in Oxford over the years, which sort of answer clinically, I think, important questions based upon the good fortune that we have of a large number of pituitary patients. And so that's the purpose of the talk. And acromegaly goes back many years. This is Akhenaten. Some people think he had acromegaly. I don't know whether you do, Bill, but I don't think he did. But he certainly had prognathism and some of the features you put up earlier in your talk of acromegaly with prognathism and a big nose. But you'll, of course, know that he fathered a daughter, and so I think he's unlikely to have been hypopituitary. And then on the next slide is the different sizes of pituitary tumours, and we all know from the studies that we've all done that on the left, a microadenoma has a very good rate of growth. It doesn't grow at all very much, and I'll show you some data on that, whereas a macroadenoma does grow, and I'll show you data on that. But importantly, the two tumour types respond very differently to all forms of treatment, particularly to drug treatment, to surgical treatment, and to radiotherapy. So I think that the size of the tumour, if nothing else, is absolutely key to how the patients do. Now, you're all familiar with the classification of pituitary tumours, and I won't dwell on that. But the frequency of them is done, as we published in a study from Banbury, looking at the prevalence of these tumours. And you all know that non-functioning tumours are much commoner, less common rather than prolactinomas, followed by acromegaly and very rarely Cushing's disease. And so those are the prevalences in this fine IT community in Banbury in Oxfordshire. Now, Marta talked about the hyperprolactinemia that you can sometimes see with non-functioning tumours, and this is a study we did a little while back now, showing that the cutoff is essentially around 2,000 milliunits, that's 100 nanograms per mil, and above that level you're much more likely to have a prolactinoma, and below that level you're much more likely to have a non-functioning tumour. And I think that that's an important thing when you're faced with a patient with a macroadenoma and you see a high prolactin, which is not in the astronomical range of above 3,000, say, those patients are much more likely to have a prolactinoma. And of course, that makes a huge difference on what treatment you give these patients, i.e., whether it's surgical treatment or medical treatment. What is the natural history? And this is another study we did with Nikki Karavitaki, who's worked with me and now is in Birmingham, but we had a very fruitful collaboration over many years. And the question was, what is the natural history of a non-operated, non-functioning pituitary adenoma? And we put together all our cases in Oxford over a number of years, patients who looked as if they had a non-functioning tumour, but for various ethical reasons, they weren't operated on. And we looked at them. We have a position where we scan these patients every year in Oxford and looked at them over the years to see what happened to the tumours. And as you can see on the top line there, the number of macroadenomas we had was around 40, and the number of macroadenomas around the same time. And you can see here that the follow-up was there, and the increase in size was a very small number of microprolactinomas, and about half the patients had an increase in size who had a macroadenoma. This study went on over 4 years, and the timing of these things is absolutely key, so that at 4 years, a number of 50% of macroadenomas had increased in size. And of those, 50% had new visual field defects. And 4 years, as you'll know, is a very short time in the natural history of a pituitary tumour, so that if we'd followed these patients up for longer, the figure for enlargement of a macroadenoma would have increased significantly. The purpose of that really is to say that if you've got a patient with a microadenoma, based on our study and others as well, they're very unlikely to change in size, and we would normally do a scan at a year and then not worry about a patient if they hadn't changed. With a macroadenoma, though, it's different, and these patients can increase in size. And so I think that if we're faced, Simon and I, if we're faced with a macroadenoma, would think about operating on the basis that 50% of them will increase in size in 4 years. And you might as well get on and remove a tumor in a benign operation if it's likely to increase in size, which based on these data it is. And these are the graphs which you put in the paper on the microadenomas at the top and the macroadenomas at the bottom. And I think that's relevant information if you're faced with a patient who's got a macroadenoma but not yet got visual field defects. The next study I wanted to report was the one we did on pituitary apoplexy, because I'd thought that if you have pituitary apoplexy, you're not going to have any problems with increasing tumor size. But in fact, this is not the case. And this is Aparna Pal, who now runs the department in Oxford, who did this paper. And we looked at a number of patients with classical pituitary apoplexy, followed up over a period of time, and showed that 11% of them had a change in their pituitary tumor size over 51 months. And so basically, these patients with apoplexy can have an increase in their pituitary tumors, therefore they do need follow-up longer term. But the comparative figure for non-apoplexy patients in the studies that we've done and published shows that at this period of time, around 35% of patients have an increase. So the number of patients who increase after apoplexy is lower than normal, but it does occur, and I think that's important, and that's the graph showing that we published. The next thing I thought to myself was, well, can we ever stop imaging these patients? How long do we have to carry on imaging them? Can we just not stop at 10 years if they haven't changed in size? And so what we did here was to look at a group of patients, a large number of patients, followed up for greater than 20 years in a significant proportion. The mean follow-up was 6 years. And what we showed was that regrowth occurred, as I just said, in around 35%. Importantly, despite the fact that we were following these patients at yearly intervals and then after 6 years at 2 yearly intervals, 20% relapsed at greater than 10 years after their initial operation. And I think that that's an important piece of information, which means that, again, you can't stop following these patients up radiologically. And this is the breakdown that we did, looking at the patients who had a 3-month post-operative scan, just like Bill Young's protocol. We do a scan at 3 months, and based on that, if it's an empty cellar, the recurrence rate is low. If the tumor's in the cellar, that's the recurrence rate. And if the tumor's outside the cellar post-op, that's the recurrence rate. And so from the practical point of view, in Oxford, what we do is to image the patient if they've got no tumor post-operatively every couple of years. If they've got tumor in the cellar, we'll image them every year for the first 5 or 6 years. And if they've got extracellular tumor post-operatively, we'll then consider radiotherapy. And that's something which is how we manage it in Oxford. And this is our sort of follow-up algorithm for patients who've had a non-functioning tumor. We assess them pre-operatively. We put them on T3. This is not terribly widely done. We put them on T3 perioperatively because 12% of them have a recovery of their pituitary function post-operatively, and it's easier to take them off their T3. I think I started doing that at Bart's, actually, Marta. But anyway, we've carried on doing it. And then we do a 3-month post-operative scan, and if there's little residual tumor, we do the MRIs, and if there's extracellular tumor, we'll think about radiotherapy. Indications for post-operative radiotherapy, I think, are fairly clear. If there's residual pituitary tumor, if it's sometimes a difficult resection or a very hard tumor, and we all know the side effects of radiotherapy, including, most importantly, I think, cerebrovascular disease and late tumor development. And then recently, one of our lovely Romanian fellows published this paper on protocols which actually, if you replace these patients carefully, their quality of life is normal. And I think that's really quite important that you can actually achieve that in a specialist pituitary unit. What about aggressive tumours? And Marta's already mentioned temozolomide, and I think this is something which is important, and Anne McCormack in Australia and Sydney has done quite a lot of work on this, relating the response to temozolomide to the MGMT status. And it's a very useful drug which has been used since 2006, mostly in the treatment of malignant brain tumours. And we know a lot about pituitary tumours now, and this is a patient from Denmark who had an aggressive tumor, which you can see change very radically in size with temozolomide. So patients do respond. Prolactin Omas respond most frequently, as you can see there from Anne McCormack's paper. ACTH-secreting tumors respond to 60% and non-functioning tumors less often. Response is always evident in the first 3 months, and I think that if they haven't responded at 3 months, probably the treatment can be discontinued. And I think that there's a need for further trials in temozolomide to look at multi-center trials. How long do we carry on with the temozolomide? And then there are other therapies which can be used as well as temozolomide if the patient does have a recurrence. And I think importantly, we need more long-term data on temozolomide. And how do we manage these patients? Well, with surgery, then a post-op scan, and then radiotherapy, and then possibly further surgery, temozolomide, and then I think we're on to experimental treatment. Now, Prolactin Oma has been covered by Marta, and you know that this is the commonest pituitary tumor, and you know the clinical features of this. And I think that the important things are drugs, and as Marta very well described, these commonly do present with hyperprolactinemia, and a lot of people don't realize about drugs and what the causes are. Interestingly, with drugs, the raise of the prolactin very rarely goes above 3,000 milliunits per liter, and I think that can be useful. And then hypothyroidism is something which is often missed, particularly in young people who have hyperprolactinemia and non-clinical hypothyroidism, and I think that's easily missed. Macroprolactinemia is important, and I think most labs in the UK anyway routinely measure macroprolactin now, but it is an important cause when the patient has hyperprolactinemia and their reproductive function continues and they continue having regular periods. Dopamine agonist resistance is important, and the paper we published on CSF rhinorrhea shows a much higher frequency of dopamine agonist resistance in the patients who developed CSF rhinorrhea. I don't think any of us know quite why prolactinomas have the unique propensity to cause CSF rhinorrhea. But failure of normalization of the prolactin, failure of the tumor to decrease in size of the definitions of it as produced by Mark Molich. And we know that cabergoline is the most effective drug and the least frequently associated with resistance. Now, another thing which hasn't been discussed yet this morning is pituitary malfunction and prolactin Oma. And another study we've done, which we've published on now, was answering the question, if you have a patient who's got a prolactin Oma that presents to you with hypopituitarism, is that going to recover? And I'd always thought at Barts that they would recover, and so we did a prospective study looking at a number of patients over a period of years. All achieved a normal prolactin, all had significant pituitary tumor shrinkage, and we looked at their pituitary function on an annual basis over a period of years. And you can see here that 80% of them had growth hormone deficiency, none of whom recovered. Some recovered their gonadotrophin deficiency, and I don't think that was due to tumor shrinkage. I just think that was the effects of prolactin on gonadal status more than the pituitary tumor itself. And effectively, nobody recovered ACTH or TSH secretion. So the bottom line there from the practical point of view is if you've got somebody who's deficient of various of the hormones, who's got a prolactin Oma, they're very unlikely to recover over the period of treatment, and therefore you might as well give them replacement therapy at the beginning of treatment rather than waiting for them to recover, because they don't. The only thing is the exception there is actually looking at gonadal function, and what we would do is give them treatment for hypogonadism and then take them off it at a year to see whether it has recovered. Now, Marta's already mentioned this recurrence of hyperprolactinemia, and this is our contribution to this literature, showing effectively our figures were 80%, I think, who actually have a recurrence of hyperprolactinemia, 93%, even higher than the paper that Marta quoted. And so basically, I think that if you're talking about a macroprolactinoma, and Marta gave very clearly the guidelines for stopping treatment, I don't think that most people would now stop dopamine agonist therapy in patients with a macroprolactinoma, because the recurrence rate in our paper there is 93%. They take a little while to recover, some 8 months, but mean prolactin at baseline was 28,000, on treatment was low, and then came up again. So that the characteristic thing when they do recur is that the prolactin comes up, but it doesn't go anywhere near as high as it was when they first started treatment. I'm just going to mention how am I doing for time, not too badly. So this is acromegaly, and you've been described very nicely by Bill the features of acromegaly, which has a prevalence of 40 to 80 cases per million, and this is 4 to 6 per million of the population of new cases. And these are data from Jens Otto Jürgensen, published at the American Endocrine Society a few years ago. And we know the important data that shows how important it is to get growth hormone under control and IGF-1 under control for increasing the mortality very significantly, and that's why it's done. What hasn't had so much attention paid to it is actually now that we have the wherewithal to give treatment which actually cures the acromegaly. So if you use a high enough dose of pegvisomant, you'll get the IGF-1 under control. And even in a reasonably experienced unit like ours in Oxford, we looked now a few years ago to see how often we controlled these patients. And it wasn't by any means as high as one would like. And so this is our cohort in Oxford. Growth hormone was under control, which I mean less than 1, in 57% and not controlled 38%. IGF-1 was controlled in 55 and not controlled in 30. And so basically, even in a reasonably experienced unit, as I say, we're not always controlling acromegaly as well as we should. And I think that that's important because sometimes it's the expense of the drug, and Bill went into the details of that very effectively, showing how very expensive these drugs are. And in some parts of the UK, up until a few years ago, it was very difficult to get hold of pegvisomant treatment because it wouldn't be funded. And so I think that there's the cost. A lot of these patients are quite elderly. Another thing that's not clear, and we're just beginning to look into this in the acromegaly, UK acromegaly database, which has 3,000 patients in it, is the disparity, so that in some patients there's a normal IGF-1 and an abnormal growth hormone, or vice versa. And nobody really knows what the effect of this disproportionate analyses is. So if you've got a high IGF-1 and normal growth hormone, or vice versa, as I say, does that affect your mortality and morbidity? And nobody really knows this. And so at the moment, we're just trying to answer that question. But the bottom line is that we don't always control acromegaly as well as we can or could or should for various reasons. This is the first data that we put out some years ago showing the effect of experience on pituitary surgical outcomes. And I think it's important, and this is Simon's predecessor, Chris Adams, curing about 50% when he started and then going up to 80% when he finished. And those figures, he was curing 90 to 100% of microadenomas, so that these figures vary, as I said, according to tumor size, but surgical experience is clear, and the work from Boston, from Brooke Schwieringen and others have confirmed this very well, I would say. And so surgical experience is absolutely key. And then the next thing is the outcomes with somatostatin analogs, because although the textbooks say that a high proportion of patients do have a response, this is entirely predicated on the pre-treatment growth hormone. And this is some data I put together a few years ago showing how important that was, so that if you have a low pre-treatment growth hormone, your response to somatostatin analogs was high, whereas if you have a high one, it's very low at 14%. And so I think that's important too. And then the next thing that's important is, should we or should we not debulk the tumor? And a few years ago, there was a very strong protagonism of, well, if you can't cure the patient based upon the preoperative surgical imaging, well, you might as well not even bother. And I think, and we showed that that was completely wrong. And so surgical debulking of pituitary macroadenoma improves control by lanreotide. And this is a study we did and published a few years ago where we pre-treated them with lanreotide, got to a nadir pre-treatment, pre-surgery growth hormone, and then compared that with the surgical operation and then re-exposing them, if necessary, to lanreotide post-operatively. And you can see here the preoperative lanreotide and the post-operative lanreotide in columns. And in each case, the post-operative growth hormone on lanreotide was lower. And in 50% of those cases, the patients were effectively cured on lanreotide, whereas none of them were cured preoperatively. And so surgical debulking is definitely worthwhile. And that's an important point that I think should be made. Now, how do we treat patients with acromegaly? I think we'll obviously operate on them. Simon, in some cases, does pre-treat them with somatostatin analogs. But if they're cured, then we follow them up on an annual basis, and the recurrence rate is around 7% at 10 years, so they do recur, but nowhere near as frequently as patients with Cushing's disease recur. If they've got a macroadenoma, then and they're cured, well, we're fine. But if they haven't, then we'll normally give them a dopamine agonist first because it's least expensive. And although only 20% of them respond, if they do respond, that's the least expensive long-term treatment. Then we'll give somatostatin analogs, and the response rate for that varies, but around 20 to 30%. And with pasiriotide, it's around 30% of response. And then if they don't respond to that, then we'll think about giving radiotherapy. And in the UK, we need to give radiotherapy at the same time as pegvisomant because long-term prescriptions of pegvisomant are obviously very, very high. So how do we monitor our acromegalic patients? Well, we'll do an annual GTT or an isolated growth hormone. If they're just routine and they're cured of their acromegaly, I'll just do a growth hormone and an IGF-1. We don't do a pituitary MRI unless they've had a recurrence biochemically. We keep an eye on their blood pressure and their echocardiogram. We obviously keep an eye on their carbohydrate metabolism. One thing is really important, and that's in the early diagnosis of acromegaly, is that the rheumatological effects of growth hormone excess do not reverse, and that's one of the important reasons for diagnosing acromegaly early. And then the other question is whether these patients have a higher risk of colon cancer, which I think they likely do. But we normally routinely screen them if they're greater than 40 at presentation and then every 5 years. And if they've got cured acromegaly and they don't have any polyps, we'll put them back to what I would call normal population screening. And for the breast and the prostate, we'll do normal population screening because as far as I'm concerned anyway, the frequency of breast cancer and prostate cancer is not increased in acromegaly. And so the last slide is our giant. That's me on the right-hand side looking a bit like a growth hormone deficient person, and Chris Greener, who died last year, actually aged 70, so he got a lot further than Robert Wadlow, and he was our tallest man in England and was diagnosed rather late when he presented to his GP. He presented to at 14 when he was thought to be tall. He was 6'7" at the age of 14, and his GP thought he came from a very tall family and sent him away again, but he was eventually diagnosed with a huge pituitary tumour when he was 22. So the important thing there is early diagnosis of pituitary tumours, and Bill said 8 years for acromegaly, it's a long time. Cushing's takes a long time. Prolactin Omas sometimes take a long time. I think the important thing is to early diagnose them, and I hope and think that all of you have seen an acromegalic on the street, driving your taxi in the Royal Opera House or wherever it is, and tell them that they've got acromegaly, because I think it's really important that they know as soon as they possibly can. Thank you.